Outstanding. So I got my timer going. Action. See, action. This is our clicker. You know, you make do with what you got. Howdy, y'all. I'm Dr. Jeff Jarvis, and I want to go over our first protocol review module, or PRM. The one we're going to start with is behavioral emergencies and agitation. Now, the reason that I am revising this protocol is to better reflect my experience in taking care of patients with behavioral emergencies and agitation. What I have found is that this is not a black and white situation. It is a spectrum. These patients present on a spectrum of agitation. That means anywhere from mild agitation to they're delirious and violent. And there is no black and white differentiation between these patients. There is a continuum between there. That also means that there is a continuum in our approach to management. So, for example, there is some overlap in presentation between, say, a patient with mild agitation and moderate agitation, between moderate agitation and severe agitation, and between severe agitation and outright overt violence. And just like there is that overlap, there are overlaps in how we appropriately manage patients. So, for example, a patient with moderate agitation may effectively be managed with one medication or another. There are multiple approaches to how to manage them. So I wanted to write a protocol that I felt better reflected this. This is how I practice in the emergency department. It's how I practice in the field, and I think it is the practice that best reflects reality. So I also think this protocol is a great example of my overall thinking and approach to writing protocols. This protocol is a toolbox. It is full of tools that you can pick from to match and best serve the patient that is in front of you. I've been doing this a long time, but there is no way that I can accurately identify what every patient is going to look like in front of you. There's no way I can do it, and I'm not even going to try. That is the reason that I trust you as clinicians to make educated decisions about what's going on with the patient, and I want to give you the tools you need to best approach the patient that's in front of you. So before we get into the meat of this particular protocol, I want to acknowledge the climate that we're currently working in, the elephant in the room, if you will. As of right now, this is June 2nd, 2023, there are at least 2 cases that I'm aware of, and I'm sure there are actually more, in which medics and firefighters are facing criminal charges in association with the death of a patient that was in their care. Both of these situations were when law enforcement was involved, and obviously there are tons of cases in which law enforcement is charged in these types of situations. What that means is that we need to be very careful about our approach to these patients. Specifically, it means that we need to make sure we are doing everything we can to keep this patient's needs at the forefront of what we're doing. We clearly need to assure our safety and the safety of our colleagues, and our police partners need to assure the safety of the community, but we have to do it in a way that also makes sure that we are taking care of this patient. So I think this protocol will help us do that. So with that in mind, I want to state the obvious. I don't want there to be any miscommunication about this. I want to say as clearly as I possibly can, it is never, 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 never appropriate for EMS to sedate or restrain a patient at the orders of a police officer. Certainly never appropriate to sedate a patient solely to facilitate the arrest of a person who does not have a medical emergency. We are not involved in law enforcement. That is their job, not ours. Our job is to take care of this patient. Now, fortunately, I don't think that puts us at odds with our police partners. We both want what is best for this individual, but we also have to take into consideration what's going on with the overall community. So, never, ever, ever give a drug solely for, say, facilitation of an arrest. Now, the good news is I do not believe our police partners are asking us to do that, and I don't believe that you would do it even if they did ask. But some things are worth repeating, and the reason I bring this up is those are the actual accusations against these paramedics, EMTs, and firefighters who are facing criminal charges. There was a lot of press about police officers ordering paramedics to administer particularly ketamine to facilitate an arrest. We all know that doesn't happen, but that is what is being portrayed in the media, and we need to be crystal clear about it. So with that in mind, let's dive into the protocol, shall we? Now, this protocol is associated with an appendix that contains the RASS score. That is the Richmond Agitation Sedation Score, and that is a way of relatively objectively identifying and documenting how agitated a patient is. That'll be in an appendix. There will also be a procedure that is new, and that is about physical restraint. This is about the medicine, but it certainly references both of those two other documents, and it'll be hyperlinked in the app. So let's start off with what the basic approach is, something we're going to do for all patients, and that is most certainly protect ourselves, protect our colleagues. Try to do everything you can to verbally de-escalate the situation. Our objective is to calm the patient and care for them in a way that doesn't involve medications, that doesn't involve restraint. If we do have to physically restrain a patient, we need to make sure that we're doing it in conjunction with the steps outlined in the protocol. Now, one of the reasons that patients may be agitated is it may be that they are postictal, in which case the best treatment for them is to leave them alone. It may be that they're agitated because they're hypoglycemic, in which case we need to recognize that by assessing their glucose level and obviously giving them glucose. We also absolutely positively need to monitor the vital signs on these patients. The situations we have seen in the media in which patients die in custody have largely been because not they were being restrained, but the way they were being restrained and the fact that we were not monitoring them. We have to monitor these patients. That includes blood pressure, EKG, if you have that equipment available, pulse oximetry, and most importantly, waveform entitled CO2. We got to do that on all of these patients. Now, at the assist level, we do have some medications available, and we have a new requirement, and that requirement is the RASS score. You need to document a RASS score before and after any pharmacologic intervention. So let's go over the RASS score now, shall we? So the RASS score is a score from -5, which is unconscious, unresponsive. They're not responding to verbal, pain, nothing. They are out, complete anesthesia, up to +4, which is combative and violent. These patients are exhibiting outright overt combativeness and violence. Now, that is a continuum in between from +4 all the way down to -5. 0 is alert and calm, and 0 is our target. We want them to be alert and calm. We don't want them to be unconscious. Now, having said that, I recognize that when people are, say, +4, they're violent, and we have to take them down rapidly for their benefit, and for ours, we hit them with ketamine, for example. I recognize that we are highly likely to go way past 0 and down to -5. I get that, and that's okay. The main thing we're looking for is 0, but the safest way for that patient to get to 0 was through -5. That is okay. I just don't want to redose the patient if they're already at -5. So that's the RASS scale. We will have this available in your app. We'll also have it available in ImageTrend, and we are creating a way for you to document this in ImageTrend. Again, I want you to document this at a minimum before and after each sedative you give, and then I want you to document a final RASS score on patients that you have sedated. If you're not sedating the patient, they're not agitated, you don't need to do this. We will also be using this score, by the way, if we are sedating a patient for airway management. Now, when it comes to medications, I mentioned there is a spectrum. So the protocol is laid out in a way that recognizes this spectrum and goes from a RASS of +1, that is anxiety or mild agitation, all the way up to a RASS score of +4, violent agitation with delirium. And that word with delirium bears repeating. Delirium means altered mental status. They are not reasonable. They can't be reasoned with. They don't follow directions. They don't understand what you're saying. If a patient is violent but understands the situation, that is not delirium. That is pissed off, and that is not a medical issue. So when we are sedating patients because they have a RASS of 4, because they're violent, they must have altered mental status. By definition, they cannot have decisional capacity. If they have decisional capacity, they are not, this is the wrong definition. That's not them. So let's take a look at the tools we have available. At the assist level, we have midazolam. This is essentially what we've had in our prior protocols. At the far mild end of the spectrum, +1, the dose is the same, 2.5 milligrams of midazolam, repeated as needed ×1. Now, as we escalate up the spectrum, we can use more midazolam. That is a dose of 5 milligrams, IV, IO, or IM, and I specifically excluded IN in this group because they are agitated and we want the medicine to work. I don't want to have to worry about whether their nose is coated with boogers and the medicine isn't going to work. Let's get it in quickly. That is 5 milligrams, and you can repeat that as needed every 10 minutes. Now you may notice that there is no maximum dose there, and that is because if they are still agitated, then they need more benzos. Now at the advanced level, we do have some additional medications that I'm adding in here. I am replacing haloperidol with droperidol. Droperidol is similar to haloperidol. It is a butyrophenone antipsychotic. It's one of the typical antipsychotics or the older psychotics. You may hear terms like atypical. That typically means newer generation antipsychotic, and those medications have a tendency to be less sedating. That's all well and good unless sedation is what you're going for. Droperidol, haloperidol, or Haldol are older drugs and are more sedating. Droperidol works a little faster than haloperidol and is more sedating. It also is more effective for other conditions in protocols that we're going to talk about later, like headache and nausea and vomiting. So the doses on this for our folks with moderate agitation, that's a RASS score of 2 to 3. We can give 5 milligrams of droperidol, IV, IO, IM, and we can repeat that at half the dose. That's 2.5 milligrams as needed for one additional dose. If they are, say, severely agitated with a RASS of 3 or 4 and you don't think they are outright violent, droperidol 10 milligrams is the drug that you're looking for, and you can repeat that at 10 minutes, again times once, at half dose. So 10 milligrams is your initial dose, then your repeat dose would be 5. If 5 was your initial dose because you didn't think they needed the full 10, then repeat that dose at 5. Now the other thing about this is it is intentionally sedating. That's the whole point. And one group of patients in particular that we don't want to oversedate is the elderly population. So these doses should be cut in half for patients over 65. Now notice ketamine is not cut in half for those patients, although I'll tell you if you need to sedate an 80-year-old with ketamine, probably says more about you than it does about the patient. Now the other thing about this is if Versed has already been given, that does not mean you cannot give droperidol. You can. That doesn't mean that if you get there and nothing has been given, you have to give Versed first. You don't. If you think droperidol is the right initial drug, well then go with droperidol. Same thing with ketamine and droperidol. I would like you to reserve ketamine for those patients that you think are an imminent threat to themselves or others, then ketamine is your drug. If they have 5 police officers holding them down, they are altered, they are irrational, they are violent, and somebody is about to get hurt, ketamine is your drug. If that is not the case, if you can manage them temporarily without getting on them, droperidol might be a better option. 10 milligrams of droperidol to be clear, but it might be a better option. The key thing to understand about this though is don't expect a rate of onset of ketamine when you give droperidol. Droperidol is going to take longer. If you don't have longer to wait, say 10 minutes, then ketamine is probably the drug. Hopefully that makes sense. Now, I said before that comment about don't give a medication or restraint solely to take the patient to jail. Well, obviously what that means is if you give sedation, the patient needs to go to the hospital. If there are any issues with the going to the hospital part, give OLPG a call. Just get as many people on that chart as you can. All right, so we've talked about the RASS score. We've also talked about which drugs to use. I do want to address one other thing, specifically about droperidol. You may have heard that droperidol was taken off of the market for a while because of a black box warning. That is a drug or a thing the FDA puts on medication package inserts warning you of badness. Well, droperidol just happened to be the first drug commonly used that got this black box warning, specifically for prolonged QT syndrome. So the idea here was there were some case reports about droperidol causing prolonged QT and then torsades. And as a result of those case reports and that black box warning, basically people just quit giving it, and then it went off the market because nobody was buying it. Well, a lot of papers have been written about this. I would definitely recommend you give me a call. I would be more than happy to share some of the background with you. But if you're into pharmaceutical company related conspiracy theories, this is a good one to look into, and I'm more than happy to feed the beast if you want the details. Bottom line is that, number one, nobody died from prolonged QT syndrome. What people die from is ventricular arrhythmias, and prolonged QT is definitely a risk factor for the arrhythmias. With that in mind, we have now gone back and looked at massive data sets looking for those ventricular arrhythmias, and we don't really see it with droperidol, even large doses of droperidol. It's safe. It turns out there is also another drug now that has that same black box warning that talks about, hey, you might not want to give this in patients with prolonged QTs, and you might want to get a 12-lead EKG. Nobody does it. We all ignore it because, well, basically we have ignored these black boxes now. It's kind of like the boy who cried wolf. We've heard about this so often and it just doesn't happen that we now have a tendency to ignore it. Lots of data about the administration of droperidol, no ventricular arrhythmias. Oh yeah, and that other black box warning, yeah, that's on Zofran. And we give Zofran like it's water. We don't see ventricular arrhythmias. Droperidol is safe. I really wouldn't worry about that. If you want to get an EKG after the patient is sedated, that's a wonderful thing to do. I don't know that you can get a 12-lead EKG if the patient actually needs the ketamine, so I'm not too worried about that. Now let's talk physical restraint. The key thing about physical restraint is we want to restrain the patient in a way that allows for the patient's safety and our safety, but doesn't put the patient at extended or increased risk. And the key thing to worry about here is positional asphyxia. Stay off the neck, allow their airway to remain open. But that is, even though it is necessary to a safe restraint, it's not sufficient. The other thing we need to do is stay off the chest. Some of these patients who are actively delusional and violent are that way because of ramped up metabolism, frequently because of methamphetamine. Their heart rate is running fast. They may be producing, say, lactic acid, and be in a situation of metabolic acidosis. We recognize that in metabolic acidosis, we are building up a lot of acids. We're converting that to CO2 and trying to blow that off as fast as we can. If you don't blow off that CO2, your hydrogen ion level gets really high and your pH gets really low, and then you die, and that's bad. Unchecked metabolic acidosis, bad, bad, bad. In some of these patients, the only way that they can protect their pH from getting unbelievably dangerously low is by breathing really, really fast. So you may see videos or see patients saying, I can't breathe, I can't breathe, I can't breathe. And our tendency is to say, well, you seem to be breathing well enough to say, I can't breathe. But this person just doesn't understand, and they shouldn't be expected to understand, that they're suffering from metabolic acidosis, and the sensation they're feeling is not that their airway is compromised, but they're not able to breathe adequately enough to blow off their CO2. So if we restrict their chest movement, in any way restrict their tidal volume or minute volume, their pH can plummet and they can die. That's the whole point of physical restraint, is to make sure that doesn't happen. So the no-nos of physical restraint: do not position the patient in a prone position any way, shape, or form. If you have to put them face down to stop the danger that they are presenting to other people, I get it. Turn them over on their back absolutely as soon as humanly possible. Do not, under any circumstances, restrain them with their arms behind their back, tied to their legs. That's called the hog tie position. That's a no-no. That is we're going to get in trouble for that, and honestly, we should. That's dangerous for the patients. Typically speaking, for these people, we need to get them sedated and then restrained with our soft commercial devices as opposed to handcuffs. When we do restrain, not in a prone position, by the way, we need to document the steps that we took to prevent this in the first place. In other words, we had to physically restrain and chemically restrain this patient because of the threat they provided to themselves and others, and all other steps to mitigate this failed. We were not able to verbally de-escalate. We weren't able to use any less severe mechanism. We want you to document that in the chart. Also document the reason for the restraint, i.e. they were a danger to themselves or others. Talk about the types of restraints you use, the soft restraints. You will put in a physical restraint action item, if you will, as an event, a procedure. And then absolutely positively make sure that you are continuously monitoring this patient with end-tidal CO2, and SpO2, blood pressure, ECG, all of the things. End-tidal CO2 will keep us out of so much trouble. Make sure it is on and make sure you're paying attention to it. Now, if you are, say, old as dirt like I am, and maybe you trained back in the 80s where we didn't really have drugs to sedate patients, and our approach to sedation was a little on the medieval side, where we would restrain them face down on a backboard with a scoop stretcher over the top and duct taped. And I really, really wish that I was exaggerating. That is how I was taught to restrain people. That is so wrong. It is so dangerous. Please don't do that. Unfortunately, there's a history of us doing that, so we needed to put it in the protocol. That's a no-no. Don't do. If you do need to restrain a person, make sure that you have adequate resources and make sure you have law enforcement with you. If it is just, say, you and your partner, and you have a great big person who's highly agitated, cannot be reasoned with, they're violent, I don't want you even trying to restrain them. I want you getting out of Dodge, get the help you need, then come back in and restrain. Make sure you have enough people to do the job. Make sure law enforcement is there to help. Once the patient is restrained and sedated, make sure that you're giving them oxygen, that you're monitoring them, and try to elevate the head of the bed to 30 degrees if you can. And the last thing is, while you're continuously monitoring them, make sure you're doing distal motor and neurovascular checks. All right, guys, so that is the Agitation Behavioral Emergencies Protocol. That is the RASS score, and that is our restraint procedure. Hopefully this is helping We got a couple of very straightforward questions for you that come from either this video or the protocol. Remember, when you take that, this is in replace of your biannual, every other year? I can never remember that. Your protocol exam. I think you'll like this better. If you have any questions about anything and suggestions, please let me know. Y'all stay safe, be careful, and take care.